All right. Looks like it's a little after 6. We'll go ahead and get started. Hope everybody's doing all right tonight. Others can jump on when they get on here. But tonight's the Airway lecture, and it is quite a long one. That's why it's split up over 2 nights. Starting off the first part of it, quite a bit of review on the A&P part of it, but that's something we'll never get away from. But because it never hurts to review that. But Airway is one of the most important subject that we can cover in the healthcare field, because without it, nothing really ever matters at all. Uh, don't get past that part, because if you look at it, pretty much the way the body functions, especially the airway, pulmonary system, functions to carry the brain around. Just about every system we have, it can be related to carrying the brain around, keeping the brain alive in some form. Respiration, one of the first terms we'll talk about tonight, has to do with it's divided up into 3 different categories, and respiration is simply gas exchange. It it differs in what one would call ventilation. It's mainly the movement of air in and out, but respiration is where gas exchange takes place, and talks about external. That's moving air into the large airways, mouth, nose, trachea. Internal has to do within the distal terminal ends of the airway, bronchioles, the tributaries to the alveoli in that way. And then, of course, at the cellular level is the gas exchange between the alveoli and the red blood cells. So that's the, as far as cellular respiration, and that takes place in every uh, cell within the body. Once the blood has to get to takes the oxygen to the blood cell, to the cells, and it makes a trade off. They have to give up some oxygen in order to get some CO2 to bring it out. So the artificial ventilation. Anytime you hear the word artificial, that in the medical field, that's going to be in relation to something being done outside of what the body's been able to do itself. So we're going to talk about artificial ventilation in a little while, and a few more terms that's pretty important to remember. And as we'll talk about ventilators and stuff later on, and based on local protocol and guidelines, determines on who may or may not be using those, but we will have to touch on some of those. And I find that stuff kind of pretty interesting. But artificial ventilation, we'll talk about that later. Minute ventilation, we'll learn some formulas and some information surrounding what that concerns. And minute ventilation is simply how much air someone moves in and out of their lungs in a minute time. And that's measured by the tidal volume and by the respiratory rate. So if someone was breathing, let's say they were moving 500 cc's of air with each breath, and you do that times 60, that would 3,000 would be their minute volume. There's also formulas that when we talk about ventilator management and strategies as to how much, I'll hit on a little bit later as well. But for example, everyone requires a certain amount of minute ventilation to function. And one way we would figure that out would be to figure someone's ideal body weight. If you have someone, let's say a male that is 6 foot, 6 foot tall, make him 72 inches. Anything over 60 inches, they multiply that by 2.3 equals 27.6 plus the 60. And it gives them about, let's say, 120. So we said that would earlier with just a rough generation about 3,000 cc's of air. For example, someone 6 foot tall, a male 6 foot tall, would require about 9.3 liters of O2 per minute. And if we divide that up by what their, let's say their tidal volume would be, let's say 500, that means that they would have to breathe, we'd have to set their ventilatory rate about 18 times a minute in order to get that. That's something we're not going to have to worry about now. It just gives you a rough idea of how that's measured and how it actually is a physiological requirement of individuals. And the alveolar ventilation, which occurs, that's air getting down to the alveoli. It may get there. We'll talk about VQ mismatch a little bit later, but the air may get to the alveoli as far as ventilation, but it doesn't necessarily mean that respiration will occur. It could be because there's too much fluid in between, or it's inflamed, or the cell wall of the alveoli is broken down. So just because it gets there doesn't mean that it's actually providing respiration. But right now we're simply just talking about the movement in. Artificial ventilation, when we bag somebody or ventilate them with a bag valve mask, or even if you have an advanced airway in place, we got to keep them in what would be their normal rate would be if they were breathing on their own. Because if you breathe in, if you push in too much air, either by too much of a volume, like if you squeeze the bag all the way with both hands, you're going to overfill the lungs. Or if you're moving air in and out faster than what it should be, what that artificial ventilation does on cardiac output is all that increased air in the chest cavity. If you got too much air in there, that's much less blood that can get in and refill the heart, or it makes the blood hard to get out of the heart to go to the peripheral areas of the body. So adequate and the appropriate amount of ventilation rate, not only the rate, but the amount that you put in, can have an effect on someone's cardiac output. So we'll talk about that a little bit later, but bear that in mind also. Now, pathophysiology is a word we heard earlier. This gets a little bit more deeper in depth into the way the cells of the pulmonary system, the gases in the blood function. Once getting an airway and hanging on to it, that is the paramount step that you're going to have treating patients in EMS. Once you get the airway, you may get it initially, but hanging on to it may prove another challenge. For example, you may have swelling or fluid that accumulates in the airway, or you can lose or have an advanced airway dislodged, and that's going to cause you to have to reinsert it. And sometimes once you take one out, it's very difficult to get it back in. So we'll talk about maintaining the airway, securing these advanced airways a little later. The oxygen during inhalation, it moves. Let's say if we don't have any supplemental oxygen, but given just the regular amount of oxygen in the atmosphere, which is 21%, moves from the atmosphere into the lungs. That's inhalation, that's active. And exhalation is when the carbon dioxide leaves the body. It's not just pure carbon dioxide that goes out. Same way, it's not just pure oxygen that goes in. There's a lot of other inert gases that are in there as well. So these are the most crucial skills that any EMS provider can learn: obtaining, maintaining the airway, and maintaining oxygenation. The airway, we'll see a picture in just a moment, but it is divided into the upper and the lower airways. The upper airway is simply that from the mouth to the larynx. So your mouth, nose, oral pharynx, nasal pharynx, all that is considered your upper airway. Now, once you get to the glottic opening, which is the voice box or larynx in this case, that's when the lower airway begins. The ventilation, of course, is the air exchange. Respiration is a gas exchange. So kind of remember it that way. Ventilation is movement of air. Respiration is the exchange of gases. Now, you got other structures that aid in ventilation. And the one that comes to mind first is the diaphragm. It's like a sheet muscle. And when I say sheet muscle, it's like a sheet that's inside the body, but it's muscular and it has a dome-like shape when it is relaxed. And when it contracts, it goes down, and that's what pulls the air in. It forms a vacuum inside the chest cavity and actually draws the air in. Now, the other muscles, you got muscles that are support the chest and the back, the muscles of the diaphragm that support it to areas below the diaphragm, which kind of pulls it against the back to help move it up and down. But those are muscles of breathing, is what we call them, and they are accessory muscles. Most of the time, it doesn't take a lot of effort under normal circumstances to take breaths. However, if someone is distressed, whether it be because the gas exchange is not good, or if it's because the anatomical structure of the lungs are messed up itself, then they may have to start using accessory muscles in order to be able to meet their respiratory demand. Now, this diagram here, if you look at it straight on, remember if I refer to any right or left, I'm referring to the patient's right. But as you can see, the diaphragm is like a flat dome-shaped sheet muscle, and that's what separates the thorax from the abdominal cavity. It's attached on the rib cage. Pretty much it goes, if you think of like one of those dome tents that sets up in the bottom of your rib cage, that's kind of a good ideal way to picture it. But it's attached to the bottom of the ribs, and it comes up as high as almost just below the nipple line is about how far up that diaphragm comes. And it has, and you see the chest wall, the muscular chest wall, the muscular diaphragm, all of that forms a container or cavity around the lungs themselves. Now, the muscle area has that parietal pleura around it. It's really a big sac, but it's lubricated. It's got two sides to it. The parietal pleura is the one that touches the muscle wall. The visceral pleura is the one that covers the lungs themselves. And in between those two pleura, that's when they have this lubrication. It's very slick, viscous, and it provides the lungs a space where they can glide back and forth and hopefully not create any type of friction. Now, areas of friction that could occur would be like if they have pleurisy, or we talked about a pleuritic rub a couple nights ago. That's where it will occur between the visceral and parietal pleura, and it can even happen on the bottom side of the lungs, and this be very painful because it's a grating type noise. You can see up at the top, if you start at the head, you get the nasal pharynx, the oral pharynx, the mouth, and it comes down to the point of the epiglottis. That is that structure is when someone swallows, it folds over the opening of the vocal cords to prevent food from coming in. And you can see the trachea right where it says larynx. No, the top of the larynx, below the larynx is where you start the lower airway anatomy. And as you can see, the trachea and the part to where it separates to where it forks. A couple of terms that you'll learn there. That is called it's a bifurcation. It's when something divides and forks. If it forks just in two places, into two areas, it becomes a bifurcation. But that site to where that happens is called the carina. And if we were to insert like a endotracheal tube or anything into that area, what would happen there would be you don't want it to go all the way down the right main stem. For instance, right in there, the carina is, if someone was to intubate this patient or put in an oral tracheal airway, it would have to sit right above the level of the carina. If it goes too far down, then it's going to go into one side or the other, mainly the right main stem, and cause ventilation just to one side, and all of that other lung tissue would not get any ventilation. And that's not good. You'd have to back it up to where they both can get it. As you can see how at the point of the carina, the bronchi divide into bronchioles, which is smaller tubes that gets into the alveoli and the lung tissue, and it even breaks up even further than that, and they call them bronchioles. Now, the bottom right hand of that picture, it shows how the terminal airways divide into the alveoli. Now, the alveoli is, if you look at the inside, it's kind of grape-like clusters, and there's a lot of very small capillaries, pulmonary capillaries. That's where the arteries and the veins come together, and they surround those alveoli and provide gas exchange. Those are very, very minute capillaries where it probably only can be seen under a microscope, something that magnifies to that point. So that's the upper airway and the lower airway. Upper airway is that above the larynx. Lower airway is that simply below the larynx. Now, the upper airway, what it's for, it's a filter. It's to gather the lungs, the air to funnel toward the lungs. It's to also filter it. That's why breathing through the nose is the way that the airway system is set up, because it's supposed to have hairs and the large mucous membranes in there that warm the air, they humidify it. Now, when you breathe through the mouth, sometimes people may cough something a little bit more, or inhale larger objects, and it will kind of dry your throat out a lot if you continually to breathe through the mouth. If you've ever woke up, been snoring all night with your mouth open, you wake up with that big dry mouth, that's because the oral passages do not lubricate and humidify like the nasal passages does. Now, the area behind the oral cavity and the nasal cavity, the pharynx, that comes from the back of the nose all the way to the top of the larynx, and it is divided up. The pharynx is that is simply the back of the nose all the way to the top of the larynx. It's divided up as far as some regional areas, like the part that's in the nose. Of course, nasal pharynx, oral pharynx has to do with the mouth, and the laryngeal pharynx is that area right around the larynx itself. The laryngeal pharynx is the lowest part of it. It's right above the trachea, and the bottom part is probably the smallest. The oral pharynx will be the largest part, but the laryngeal pharynx is the lowest portion of the pharynx, right above the larynx. This picture here is it's a pretty good picture. I hope you can see it pretty good. But of course, on the left, you can see when we talk about under the tongue, the tongue is raised up, and that's what we call a sublingual area. Anything sub, when you hear the word sub, it means below. So we're looking at, if you raise the tongue up, that is some very vascular mucous membrane in there. It's very absorbent. That's why some medications are given sublingual, like aspirin and other type of medications, some type of nausea medications and some migraine medications they placed under the tongue, and they absorb directly into the bloodstream from there. And they don't get digested or anything like that in the stomach, but directly into the bloodstream. You can see the uvula hanging in the back. Now, we talked about snoring earlier and the mouth being open. That's when you do that, that's irritable, very irritative to the structures inside the mouth. And that uvula, sometimes if you ever wake up in dry mouth and or maybe even hoarse, or heck, if your partner or whoever, significant other, you hear them snoring or whatever, if they wake up with a dry mouth, that uvula a lot of times will be swollen and inflamed. I've seen them to the point where it looks like a big grape back there. But it gets, and when it does that, a lot of times it will, when it gets engorged and swollen, it'll actually become a source of mucus fluid clearing their throat. That's why a lot of times in the mornings people may have that problem, and eventually it goes back down. But the uvula is a structure at the back of the throat that comes from the roof, and when we'll talk about, I know advanced EMTs don't orally intubate, but we will talk about that, and you'll have an understanding of it later, because I think it's important. But that's some structures and landmarks that you'll look for when going into advanced airways, and even examining the mouth for injuries, any type of structural difficulties or things like that. So the one on the left, that's pretty much what you should see, unless they roll their tongue back on purpose. But that's the structures that are in there. The picture in the middle, as you can see, the tongue, how much space it takes up inside the mouth. you can see it's attached to the bottom of the mouth, very, very sound. And I've always heard the wives tell growing up that someone had swallowed their tongue, or be careful, you'll swallow your tongue. Well, you'll look at it, there's no way in the world that's going to come off and you swallow it, but it will fall back against the back of it. But no one is really going to ever swallow their tongue. So you see if you follow the tongue around, you can see at the base of it, you see where it talks about a lingual tonsil, and behind that, the epiglottis. Now, the epiglottis, you see how there's not a lot of room back there. So that's why it's important, people chew their food, right? So when someone swallows, that epiglottis flaps down and blocks the opening to the vocal cords, and the food should go down back against the esophagus. And the esophagus is the most further back tube back there. But that epiglottis, when we talk about when someone orally tracheally intubates, they put that laryngoscope inside the mouth, and if they're using a curved blade, they follow the curvature of the tongue, and the end of it goes right in that area between the lingual tonsil and the epiglottis. So what they're doing is they're actually picking that up to where they can see down into the vocal cords. So that's where the laryngoscope actually goes for a curved blade. Now, if they're using a straight blade, they will actually stick it all the way to the back of the throat and even pick up the epiglottis instead of going into the little notch above it. The little notch above it is called the vallecula. But that's some important landmarks they're looking for back like that. So even think about oral airways, king airways, when we get into that a little bit later. But like an oral airway, you see how an oral airway has to be properly sized because, and it goes from the angle of the jaw, as you can see, where the angle of the jaw would be approximately on this to the end of the mouth. And you see why it has to be like that, because it holds that tongue away and still leaves the airway open. Now, one of it is too short, it's not going to go all the way back to the back of the tongue, and it's still going to cause some obstruction. And if it's too long, it can actually block the opening to the airway itself if it goes in too far. And same way with the nasal top. If you look at the nasal cavity, where that airway wants to rest is you want to get it in to where it goes back in far enough to the point to where it blocks that tongue from closing off that opening above the epiglottis. So that's kind of what inside of that should look like. Now you see the nasal cavity up there. You can't really see the bones of the nose or anything from this picture, but you kind of see where the eustachian tube, or on here it says entrance to the auditory tube. Those are working if you ever hold your nose and blow and your ears pop, because that directly goes to the ears from there. And that's why when you swallow sometime, or if you go up to high altitudes and you feel your ears like they're stopped up, it's because the pressure's unequal. And that's what those are there for. Like if someone wants to swallow or hold their nose and blow, it equalizes the pressure inside the ears. But it comes all the way into that point. And you can see some of the tonsils in those areas, they become inflamed, how they might interfere as well. The hyoid bone, it's what holds the larynx and epiglottis in place. And some people can't really feel it, but it's high up into the lower structures of the chin over there. On the right is a cutaway section of the trachea. The whole throat area, the nasal pharynx at the very top. Those four little bulbs you see, that is like nasal bones. That's inside the nose. Those are turbinates, and they are what warms the air, moisturizes it when the air comes in through the nose. Also, they can become inflamed and swell, and sometimes they can grow abnormally, and that's when someone can have like sinus drainage issues where it can't drain, or the nose constantly stays stuffed up like mine does. It's because those bones get and the tissue around those bones get swollen. They may do a septoplasty or rhinoplasty. They go in and they actually grind those bones down. I've had that done before too. However, it seems like it always comes back. The oral pharynx goes from the base of the tongue, and you're looking at this from, if you'd cut away the back of the head looking forward, that's the way you're looking at this. So it talks about the oral pharynx. You can see the tongue, you can see the uvula. This is looking at it from behind, and you see the epiglottis and how that epiglottis opens up and it covers the trachea. So that's what it's guarding there, and it simply flaps down and covers it up. And there again, was talking about putting the advanced airways in. When you lift that up, that's what you're looking at, is down a trachea to go into the vocal cords. The nasopharynx has to do with it's combined with nasal bones. We talked about the turbinates, also the septum, the nasal bones that surround that part, which are the ones behind the eyes. It forms part of the orbits. And when we talk about ciliated mucosal membrane, it has like little hair-like structures. You can't really even see them, but so these are supposed to kind of sweep material out. That's why they keep gathering. And I've never been able to find a medical term for it, but when it sweeps this mucus and this debris out of your nose, it forms like little hard clusters or whatever, and referred to as boogers. I haven't never found, if you find one, let me know, but I've searched and searched. I've never found a medical term for those. But that's what's happening. It sweeps it up toward the front of the nose where it can be gotten to or blown out. And that's what these ciliated mucosal membranes, how they work. The turbinates we just talked about, and you can, it's hard for us to see really with the materials that we have, but like ENTs and ER tools and things like that can see up in those turbinates. But sometimes if you look at somebody's face straight on, and you can see like clearly up one nasal cavity, but you can't the other one, it looks like it's blocked or whatever, that's because that septum, instead of going straight back, it's actually starting to turn like an S and it's deviated. So that's actually what you're looking at, is actually the side of the centerpiece of that going back inward. Excuse me. Sinuses are cavities that are formed by the cranial bones that have like open spaces inside there to equalize pressure. They also accumulate fluid, and they're supposed to always, it's lined with ciliated mucosa. It's supposed to always still sweep impurities and sweeping fluid that's created out. However, sometimes due to allergies and possibly injuries, but allergies where it swells and it blocks and it can't get out, that's when it gets in there, it gets stagnant, starts to get infected. That's when someone may have like sinus infections, sinus pressure, things of that sort. Now, these bones that line the nasal cavities, on the other side of those bones, especially the ones in the top of the nasal pharynx, on the other side of those bones is the brain. And like skull fractures, trauma, things of that nature can actually cause leakages in the cranial cavity, and that's CSF, or cerebral spinal fluid, inside there can actually drain out through the nose, drain out through the ears as well, but it can drain out through the nose because those nasal bones are just on the other side of the brain cavity. Now, the nasal pharynx membranes, very, very vascular. They are very easily to bleed. A lot of blood vessels in there. That's why they swell so easy. A lot of times when someone has nasal congestion, that when those membranes swell up so big, the blood vessels aren't strong enough or have the capacity to hold the fluid in, and that's when it starts leaking out. You start getting the runny nose and start leaking out and stuff. However, even then, sometimes it gets to the point to where they get so swollen, it's not really the mucus obstructing so much as it is the membranes that are so swollen. And that's because of these blood vessels that dilate, that swell up so big. That's why like a lot of decongestants, oral decongestants, especially like Sudafed, Sudafrin, and they've got the it requires a prescription. I know it does in Mississippi. It's harder to get that than it is a lot of opioids in a lot of places. But then they have the like Sudafed PE, which is like neosynephrine. And what these are is they constrict blood vessels. That's why they tell people that have a lot of blood pressure issues or cardiac issues, and not only it shrinks the blood vessels, and it may even raise blood pressure. And in some cases, if you notice the middle word, what's that? We talked about epinephrine, speeds heart rate up, raises blood pressure, constricts blood vessels. So when it's called pseudoephedrine, it does have that property in it. So that's why there's a lot of warning labels on there about people with high blood pressure or over a certain age should not take uh, certain types of oral decongestants, because that's what it does. But it works on the blood vessels, it shrinks them down and hopes to that it'll restrict some of the blood flow. Also, they have these nasal sprays that work the same way. A lot of times it's almost the same type of medication, but it goes directly onto the membranes, and it shrinks down blood vessels and alleviates a lot of that congestion. Now, when it wears off, I don't know if you've ever heard of anybody, or maybe yourself has, been hooked on nose spray. Nose spray, sometimes people can get hooked on that, and they get in this vicious cycle to where they have to use the nose spray to shrink down those blood vessels, those inflamed nasal membranes. And then when that wears off, it gets worse every time. And then they find themselves using more and more. They'll use the 12-hour stuff, maybe every 6 hours, then every 3 hours, and then every hour they're always, it's like they carry the nasal spray with them all the time. It's a very, very hard cycle to break. I've been there. But anyway, that's how that works. That's how those work. It works against those swollen membranes in the nasal cavities. The oral pharynx is back behind the oral cavity, and we saw how it's got part of the epiglottis in it. The epiglottis almost looks like a pig's ear, if you can picture that. When like if we're looking back there to intubate or whatever, it almost looks like it's a pig's ear. Leaf shapes, made of cartilage. Base of the tongue lays over the larynx. When it works right, when things go proper, it works. When someone gets choked or something like that, that's when something may actually get lodged between the epiglottis and the vocal cords. It gets kind of trapped in there, or it can actually be big enough to where it blocks the whole area off. So with the vocal cords also contract as well. So it's kind of a partner thing that when the vocal cords close, the epiglottis falls over the trachea, the vocal cords close. That helps the airway from getting contaminated with material, food, or liquid, or anything like that. However, inside there, it has one heck of a reflex that reflex that helps to cough and get material out. Now, once it goes past, gets in just inside, it doesn't take much, but just inside the vocal cords, inside that first part of the trachea, there's some reflex cells there. And you know yourself, if you swallow your own sputum or get strangled on something, how strong the urge is to get that out. It almost takes over everything that's happening. And that's what that's made for. Is those, you also have those cilia type cells in there as well, but it is actually trying to force whatever came in there, is trying to force it out. And it doesn't take very much at all to get that done. It seems like it always happens at the most embarrassing times, however. But that is a reflex to keep that from happening. Now, the larynx itself is made of a lot of different cartilages, ligaments. It's at the top of the trachea, and all this working together, it forms that structure. Now, it can be fractured, it can be broke. It's made out of cartilage. There's no bones in it, and you can see on the front here below the very top, it looks like a saddle almost. You see the epiglottis at the top, and then you got the big cartilage ring structure around the first part of it. You got the thyrohyoid ligament, and then you got the laryngeal prominence, which is the Adam's apple itself. Now you can feel that, how it's kind of triangular shaped toward the front. It's more prominent in males than it is females, and it's a pretty good landmark in order to be able to find the tracheal deviation, tracheal alignment of that matter. Now, sometimes that trachea can be fractured, and some people might have a stridor type noise or something like that, so it doesn't hurt to palpate it and feel it, make sure everything's okay with it. Now, below that, you see the cricothyroid membrane. Try to find it on your cells right now. One of the best ways to find it is I'll put my index finger on the very tip prominence of my larynx, the laryngeal prominence, and I'll simply just roll my finger down, and simply roll it down, and it should go almost right into that cricothyroid membrane. A lot of times you can feel that, and right in that area, just a little small indentation, not very big, but you can feel where they got a change in structure there. Now, that is where the landmark to where paramedics will use to do like cricothyrotomies or needle cracks. That's where the insertion goes right there. Or the critical care medics and flight crews, can do the tracheostomies. That's the membrane that they cut in order to go in there with that. And of course, below that, you got the cartilage that sits on the top of the very end of the trachea. And as you can see how the trachea has cartilage wrapped around it in like bands that supports that structure, that softer structure underneath. So it's a pretty complex structure there, and it can become fractured. It can become injured. Some people get punched in the throat or things like that. That can be some serious injuries. You can also have, like from a fractured larynx, you can also start to develop subcutaneous emphysema in those areas. So that's one area. If you see neck trauma or laryngeal edema from the outside, you want to check that. You want to mark and you want to look and see, hey, is there any damage to it now? And then go back and look at it later, because like subcutaneous emphysema might not show up right away. Now, below the larynx, that's when the lower airway starts. That's where the gas exchanges take place. The O2 and CO2 swap places. And if you were to look about where this starts, it talks about the fourth cervical vertebrae, give or take a little bit, and down as far as the xiphoid process where the rib cage splits. That's about where the lower airway, as far as the trachea, extends to. Now, the trachea is simply like ductwork, like an HVAC system. That's simply the ductwork to get the air into the lungs. And I showed a picture earlier for when it divides, it's called, when it bifurcates, that is called the carina. This is a little more detailed picture to where it shows the bronchi breaking off into the bronchioles, smaller bronchi, and it just terminates down into the ends to where the alveoli is on the very end of that. A lot of it looks like tree branches on the inside, and not everyone develops exactly the same, but this is a pretty good idea of how these extend. Now, you see how it extends chest width? It also extends front to back as well. If we had to turn this person sideways, it would show a picture of them. It'd be the lungs taking up the whole inside of the chest cavity itself. So there again, you see how the trachea, it's not a much detailed picture here, but as it divides down, it keeps diverging to smaller and smaller airways. Now, one thing you'll look at is on the right lung, you see that there is 3 lobes in the right lung. You can see where it is separated in 3 different places. On the left lung, it only has 2. Now, they think maybe that's evolved that way because a lot of the heart sits on the left side to allow room for that. So on the right side, you got 3 lobes. On the left side, you got 2 lobes in the lungs. And there again, you see the diaphragm and about how all that sits. Now, this is a little bit of review of the visceral pleura. Think of visceral, think of organ. You might have heard the term visceral organs before, but when you heard the term as far as visceral pleura versus parietal pleura, visceral is against the organ itself. Parietal is against the thoracic cavity, or even in the abdominal. You have anything between visceral and pleura. Visceral means around the organ, and parietal means around the cavity itself. So, oxygen doesn't diffuse into the blood system until it gets down into the alveoli. The ductwork of the bronchi and bronchioles, oxygen exchange doesn't take place there. But when it gets down into the end of the alveoli, where the capillaries are right up next to the blood cells, the cells, that is where the exchange takes place. Now, your lungs have in the alveoli, it has what they call a surfactant. And it's a fluid type material. It is kind of firm. It performs structure. Uh, it's kind of, if you will, like a liquid form of, like if you put a pup tent up or pop up tent, those little uh, cables or bands that hold it open. That's kind of what the surfactant does as far as the alveoli. Now, it doesn't develop a lot of times until the like 8th or 9th month of gestation. That's why when babies are born too early, they haven't made this surfactant yet, and their lungs are so uh, have a large potential to collapse. That's why a lot of these babies have to be on. Sometimes these babies are on BiPAP, CPAP. They're intubated. It's simply because they don't have surfactant, and their lungs start to immediately collapse when they try to use them. So surfactant comes on about the last part of the 8th and 9th month of gestation. And in healthy lungs, it is there. However, it can be uh, deteriorate with disease, stagnation, or with age. And what happens here is, for example, someone that's bedridden for a long time, they may start to develop like pneumonias. And every now and then, whether you realize it or not, and you've seen somebody like you'd be sitting next to somebody, and all of a sudden you hear them just take a sigh, or they think yawning may do this as well. But what that does is someone will take a deep breath and they just kind of sigh it out, and a lot of times don't even think about it, and you may find yourself doing this without realizing it. But that's your body's way of expanding those alveoli and making sure the surfactant is getting to where it needs to be. It's kind of like throwing some more on the wall, if you will. But when someone is bedridden, can't move, or they develop what they call atelectasis, those alveoli may collapse. And when that happens, sometimes that's why a lot of people in nursing homes are bedridden get pneumonias, for example, or someone with a chest injury. They say, man, they can't expand their ribs, they can't take deep breaths. They may develop a pneumonia or something because of those alveoli collapse because the surfactant is inadequate, and it it's not able to get fluid out. It just fills with fluid, and it gets infected, and it starts a cycle. So that's what's happening there. That's why sometimes you've heard of people like in the hospital, they make them blow on those spirometers, make them blow real hard, and that back pressure is kind of like a muffler and causes those alveoli to expand. So that's could be what's going on with that. That's why there's a factor there. Now, the between the lungs, that cavity between the lungs, and has its own membrane and cavity as well. It's called the mediastinum. It's got a lot of connective tissue around it. It supports the heart. It's almost like the heart and those great vessels are in their own sac. The heart's got the pericardium, but the pericardium is also within the mediastinal cavity, surrounded by a lot of tough tissue, and it pretty much that's what holds it in place. There's no other special ligaments or anything like that that hold the heart attached, other than that mediastinum that's holding everything. They're kind of like a pendulum. Severe blunt force trauma or severe trauma can cause that to actually tear loose. So as you can see here, you got the heart, uh, the superior vena cava, the aorta, all that is in what we call the mediastinum. Now the mediastinum should be in the middle. So sometimes when if someone has like a pneumothorax, a tension pneumothorax on either the left or the right side, they talk about, man, they got a mediastinal shift. It's because it's pushing it over from where it's supposed to be. Or uh, I've heard, like we brought in a trauma patient the other night that had been hit by a car, and they said, hey, he's got a very wide mediastinum. And they got that by the X-ray. They had to send him to CT. And what would be doing that? What would be making that mediastinum widen up like that? You got to think about those great vessels in there may be torn and leaking. So that's why it's starting to swell out. But you got a large mediastinum, or it's a mediastinal shift. So that's kind of what they refer to when they got that. If you look at that diaphragm right quick, you see down at the bottom how it's got those, it's almost like an upside down U. That's some other muscles I was wanting to tell you about when we talked about accessory muscles outside of the diaphragm. But that's what borders it down to like the back and that area to kind of help it pull down as well. So it's not just attached to the sides. That's why sometimes people pull a back muscle or whatever and say, hey, it hurts to breathe, it hurts to breathe. That's kind of just letting you know, look at how that's involved and stuff. Now the phrenic nerve you can't see it on here, don't have it marked, but the phrenic nerve is what makes the diaphragm move. It controls the diaphragm. Now, you've also heard me say as well that when blood is not where it's supposed to be, it hurts real bad and it makes things get upset. So if someone has abdominal bleeding, the phrenic nerve is on the bottom side of the diaphragm. Someone has abdominal bleeding in there and they start having shoulder pain, it's because the blood is irritating that phrenic nerve, and that affects the shoulder and usually the left shoulder, but it can make it hurt real bad as well. Show a lot of referred pain to that. Now, for the respiratory system to work, it requires help from the cardiovascular system, because one couldn't really exist without the other. The respiratory system puts oxygen in the blood, takes CO2 out. That's what the brain and the body needs to survive. The cardiovascular system, after the lungs does its job, it pumps the blood. It pumps the new product, if you will, to the customers, which are the cells. So these working together, this work's supposed to work you figure every second of your life, this is what's going on. It's pretty impressive. It's a constant supply. It ensures that it takes oxygen and nutrients to the cells, but it also plays as the garbage or sanitation service as well. Because not only does it drop off good product, it picks up the bad product. And you can't just pick up one and not take the other. It's a trade-off. So they don't like to be in the same place, so they generally just swap places. We've talked about the heart before. It breaks down into the arteries, arterioles, goes into the capillaries, and the arteries carry. There's one. I don't like what this text says right here. It says arteries carry oxygenated blood, which it does, except in one case, and that's from the pulmonary artery going from the heart to the lungs. That is deoxygenated. So a better term that I'd rather use is oxygen, or arteries carry blood away from the heart, and because that one exception makes that statement not true. And the same way with veins. All veins carry deoxygenated blood except one, and that's the pulmonary vein coming from the lungs going back to the heart. So in that case, that vein is oxygenated. The cells survive when they have a constant supply of oxygen. It has to, they don't have a very long reserve at all. They need it all the time. It needs to constantly be replenished. So, especially like with the heart and the brain, they can't handle it long at all. Muscle can handle it a little bit better. So, within, some people can hold their breath just for a couple of minutes and they start feeling some palpitations. But 0 to 1 minute of deprived oxygen could start to have your heart to have some cardiac irritability. It's a lot of times when someone's having an MI, when that cardiac artery is occluded, the heart cells are not getting the oxygen in the blood that it needs. They'll start getting irritable. That's why they'll start throwing like PVCs or PACs. They'll start having dysrhythmias. Well, and that's like with a heart attack or something. But let's say the heart stops completely, no oxygen's getting there. In 4 to 6 minutes, brain damage is starting to happen. It's very possible that it's starting to happen during that point. And after 6 to 10 minutes, it's pretty much for sure that it's going to happen. And more than 10 minutes, it's irreversible to get that back. So and if they do, we've probably seen, if you've been in the transport business any period of time, you've probably seen patients in nursing homes or rehab centers that have a hypoxic brain injury, where they may have some mild deficits, or they may be totally dependent on someone else for their care. And that's because if they've been deprived without oxygen that amount of time, it's not coming back. The ventilation, think of the AC system. It's what's moving air in. It is active. In other words, it takes energy. Someone just don't lay on the floor and all of a sudden air goes in passively. They have to participate in this. And it can be, it don't have to be, when I say they have to participate, it can be involuntary, but the body's making it happen. And diaphragm contracting, intercostal muscles contracting, causing the chest cavity to expand, that's when air moves in to those areas. It is an active process. It takes energy to do this. Now, partial pressure. You may have heard terms like when they do blood gases, arterial blood gases. They talk about PaO2 or PaCO2, which is the partial pressure of those gases, and that's simply how much gas is dissolved in a fluid. In the case of ABGs, it's how much is dissolved into the blood. Now, as you can see here, we have on an A diaphragm. Picture is and they've got like a simulation on the right side where they got two balloons tied to an artificial trachea. But when that diaphragm contracts, it forms a negative pressure on the inside of the chest. And the air then is lower on the inside of the chest as on the outside, and that's when air goes in. Air goes in until it's actually equal on the outside, and that is what is considered a respiration. But air, if that capacity is torn up, for example, if they have a hole in the chest wall or one of the lungs is collapsed, then they're going to lose that vacuum, and that's when they may need help getting air in. Also, if they have an unstable chest wall, it's not able to form a vacuum like it would be otherwise, and that person would need support. And down at the bottom, you see when the diaphragm relaxes, it's causing a higher pressure on the inside than it is on the outside, and air goes away because air likes going to where the low pressure is. It wants to get away from the other high pressure. So air is going to go toward where the low pressure is to make up, to kind of equal things out. So exhalation, there again, that picture is wrong, by the way. Those arrows should be going the other way. But it doesn't require effort. Someone can, I've seen people that actually faked like they were unconscious, and what they would do is take a big deep breath of air in and hold it. No, that takes effort. So, but when someone relaxes, there's no muscular effort required. It's simply the diaphragm relaxes and the air simply goes out. There's no energy that's required here at all. Now, ventilation is regulated by factors inside the brain, structures in the brain, and also the chemoreceptors throughout the body. So it's simply a revolving cycle giving feedback. It's like, okay, hey, I got enough oxygen right now. You don't have to breathe as fast. Or, hey, I've my CO2 is under control, and it tells the brain, let's not breathe as fast. But let's say if the CO2 in the blood starts picking up, then those receptors that are in the aorta and the carotid arteries, they're going to say, okay, brain, tell the lungs to breathe faster. Let's blow this stuff off. And that usually responds to like CO2 or pH changes in the blood, and it can be according to the CSF as well. In some people, the backup system is when the oxygen level rises enough, the respiratory center might suspend the respiration, say, hey, I've got enough. We can slow down now. Don't have to breathe as hard. But that usually happens in someone where the primary system of the CO2 measurement is deteriorated. It's more like advanced COPD or something like that. But this is, these have chemoreceptors in the carotid arches and the aortic arch. And when it senses these deficiencies or excesses, that's what regulates respiratory drive. So, what is oxygenation? That's putting oxygen where it needs to be, moving it into to the bloodstream. Once it gets into the blood, that's when it combines to the hemoglobin. What is hemoglobin? It's the material on the blood cell that carries oxygen to the tissues. So it requires hemoglobin to be able to do that. You know, sometimes people can lose hemoglobin through blood loss, and that's when they talk about they doing H&H, their hematocrit hemoglobin, where they measure it. If hemoglobin's low, they're not going to be able to carry oxygen as good as they should be. Other things that affect this is like high altitudes and pressure. Now, you go to the top of Mount Everest, or if you've been in an airplane and or been to some place with high elevation to where it feels different when you're up at the top, is they still have, you know, you got 21% oxygen at sea level, you got 21% oxygen at 40,000 feet. However, the atmospheric pressure up there is different, and your body has to work harder to get that air into the lungs. That's why they'll make up for it by giving extra oxygen, or in some cases it has to be in a pressurized environment. Now, I know I was at Clingman's Dome one time in the Smokies. It's only about it's a little less than 7,000 feet. And I was carrying my daughter up the hill, and man, it wasn't no time. I mean, it hit me like, oh my God, I just run 10 miles. But it's atmospheric pressure issues. I've heard of people when they go to Denver, Colorado from Mississippi, when they get out up there and they try to exert themselves too far, they actually get short of breath because of the altitude change. And it's because of the pressure their body has to accommodate to it over a couple of days. If you've flown in an airliner, they are, going from sea level to a mile high pretty quick can sometimes affect you and make you a little bit short of breath, or you can feel the difference in some people. Now, if you get in an airliner and you're flying somewhere, they may be 40,000 feet high, but the cabin is pressurized at about 8,000 feet, which means you're still pressurized over a mile high. And I've noticed that before, getting up in an airplane, moving around, going to the restroom. I just kind of felt like, man, I feel kind of out of breath a little bit. But that's why, because it's only pressurized to about 8,000 feet. So you may feel some differences in that. And it's not the lack of oxygen, it's the lack of pressure of getting it to where it needs to be. That's why aircraft above that fly a certain altitude has to be not only oxygenated, but pressurized. Now, metabolism is the work of the process of getting energy to the cells, then utilizing it and giving it back up. Turns out to where it breaks down from material to chemicals. The body uses it, takes what it needs, processes it, and it gets rid of the waste. Like I said, it's a never-ending cycle. And the process that's used by is simply diffusion. One moving from an area of low concentration to an area of higher concentration, or simply crossing those cell membranes to get to where they need to be. Now, we touched on this term a little bit later, but external respiration, that's getting air into the respiratory system itself. It's moving it into the airways to where it can be used. The hemoglobin is the molecules that are on the blood cells, like we talked about, that carries blood. And if you're in an environment that has carbon monoxide, it's going to compete for those receptor sites on the hemoglobin. And oxygen may be dissolved in the plasma or surrounding stuff, but as far as getting on the hemoglobin, carbon monoxide will beat O2 out on that. So that's why sometimes you may not get a real accurate reading on a pulse ox with a hemoglobin. It may say 100%, and it may have 100% oxygen in the blood, but as far as getting on the hemoglobin to the cells, that CO2 is blocking it from getting there. So the exchanging of oxygen and CO2 between the alveoli and the blood and the pulmonary capillaries, it's what's happening with the external respiration. Now, remember, ventilation is the movement of air, so adequate ventilation does not guarantee adequate respiration. You may be getting air in, but it might not be crossing the alveoli barriers that we need to. And we'll talk about a VQ mismatch in a minute. So just like I said, there could be things causing that not to be able to get through to it. So we're going to talk about that in a little bit. Internal respiration is the exchange of oxygen between the circulatory system and the cells of the body. So remember that external is getting air into the respiratory system. Internal is the exchange of oxygen and CO2 between the circulatory system and the cells of the body. Now, if you look at that picture there, those little capillaries, you see how you can just imagine how small a red blood cell is. They have that concave structure and everything. So those capillaries are only big enough for about one blood cell to go through. They got to go through single file. And you can see those cells, how they're not much bigger either. So that's how minute, how delicate those walls are. As you can see, as the oxygen goes in to the blood cell, it has to change place with the CO2. It has to give it up. But like I said, and that part might not be happening if they're blocked by fluid or inflammation or something like that. The air may be getting down there, but that gas exchange may not be taking place if you've got structures or problems bothering it. And we talk about metabolism. Of course, it goes into the little organelles of the cells, the mitochondria, Golgi apparatus, and all this stuff. But the mitochondria is that powerhouse of those cells that convert glucose to energy, but it has to have oxygen to do it. So without oxygen, glucose turns to acid. We've seen how that happens. You've got DKA and stuff like that. But these cells could take glucose and turn it into energy, but it has to happen with oxygen in order to work right. And that's what they call aerobic metabolism. Remember, aerobic metabolism has to do with oxygen. That's what requires oxygen. Now, when it talks about anaerobic metabolism, that is without. Remember, the word "and" means without. So anaerobic metabolism, oxygen is not there, and it can't meet the demands of the cell. And what happens a lot of times in this case is it starts to build up lactic acid. They become acidotic. That acid in those little bitty, minute, delicate blood cells or blood vessels that you saw, it starts to eat away at those walls. When that happens, blood starts to get out and swell. Muscles start to hurt, and that's like get muscle soreness and things of that matter. Like if a muscle is overworked, that's what you're feeling when that happens. That acid getting out into those cells. Now the brain controls the actual movement of the respiratory system. You've probably heard of the medulla oblongata, the pons. It's those little structures in the brain stem. That's what they call the primitive areas of the brain, because all types of mammals and animals usually have this, but their cerebrum and cerebellum may not be as big as where all the other cognitive effects take place. But this is pretty primal, vegetative type functions. So the medullary response center control the rate, depth, and rhythm. It's in the brainstem medulla area. So you can imagine that it controls how fast someone breathes, how deep they breathe, and the rhythm means, is it regular, is it irregular, they breathe real fast, slow down, and as long as everything's getting there okay, you'll have normal respirations. However, if you have a brainstem injury, a head injury, or if you have cerebral edema inside the skull to where that brain is starting to swell and it pushes down on the medulla and the brainstem, that's when people start having irregular respiratory patterns. They start breathing, like a lot of times with head injuries, they'll start breathing real fast and slow down. Or a lot of times with like someone that's in DKA, or they have those big Kulusmals type respirations, it's because it's got all of this, your body, your brain's picking up on all of this acid, this low pH. So what it's trying to do is blow it off. So it tells your body to breathe hard and fast. Let's get this off. The apneustic center, pons, very small area, and it takes over if the medullary response center starts to fail. Now, when that usually happens, it can have what they call apneustic breathing. It can be fast, slow. It can be irregular because it's not as capable of taking care of the system as the medullary respiratory center has. And once, if those areas start to go out, get damaged, or become affected by an overbalance of negative chemicals, the pneumotaxic center, that actually kind of wants to shut breathing down. So sometimes people are severely injured. It's because maybe all of those centers are injured, and the pneumotaxic center, it inhibits these other centers from trying to make the respiratory system breathe better. So severe brain damage, brainstem injury, that's one reason they may start to stop breathing later on, have to be intubated and take over. Now, the chemoreceptors, I touched on this a little bit earlier, and what it does is when they detect a chemical imbalance, they figure out which is it. Is it too much CO2, not enough CO2? And it starts to affect, well, remember, if you got the way to correct too much CO2, and when we talk about EtCO2 and capnography later, if you got too much CO2 in the system, the body breathes harder and faster. It breathes deeper and faster. The way you get rid of CO2 is tidal volume and rate. So these chemoreceptors, again, are in the carotid arteries, and the aortic arch. That's where those chemoreceptors are. And they respond to the partial pressure of oxygen in the blood, and when the CO2 level starts to get up, they stimulate the respiratory centers to increase respiratory rate. That's why you need some CO2, but someone that may be hyperventilating may be blowing off too much because the rate's high, their volume is high, and they're blowing off too much CO2. And that's why they get them to breathe into a paper bag or to reabsorb some of that. And that's not something we really teach anymore, but that's what's going on with that. So these, that's the chemoreceptors. Remember, they're in the carotid bodies, aortic arch. They measure CO2. The central chemoreceptors outside the those arteries like that are located in the medulla area. This little chemical stimulant group, just remember, dorsal is on the back. Think of is in the back part of it, not on the actual back of you, but in that respiratory group, dorsal means next to the back. Think of the dorsal fin on a shark or dolphin or something like that. So, and ventral is along the front. The ventral veins, if you think of a fish, the ventral fins and everything is along the front of that. So remember, dorsal is toward the back, ventral is toward the front. Now, any type of disruption in this system, ventilation, respiration, any of that's going to have an immediate effect on the body, because remember the little chart I showed you earlier, it doesn't take very long for your cardiac system to start feeling irregularities, and your neurological system starts having irregularities real quick. And this is simply when there's not enough oxygen getting there. It's called hypoxia. Remember, hypo means below that what is normal. So they're not getting enough oxygen, and the cells can start to be deprived. They can start to act up. They can start to have negative effects, and they can start to die with that. Now, people that have like COPD, they got this barrel chest. A lot of time are so hyperinflated, and it's because one reason is those little alveoli in COPD patients has broken down. And there's really you might have, let's say you got 10 alveoli at the end of one of those branches. With COPD, those walls may break down. Instead of 10, you might have one big one. But think of all that surface area that's been lost by those other 10 walls that went away. But what happens here is they a lot of time can't exhale all they need to. They always have retained COPD in there. And that's why their body's like, well, heck, since they can't get rid of this COPD, we're going to stop measuring it. We'll just measure how much oxygen's in the blood. That's the kind of way that works. It's called a hypoxic drive. They don't breathe on the amount of CO2 anymore like someone without COPD does, because their body is used to it all the time. It kind of wore out its old news. It's kind of like if you got an odor in the room, after a while you get used to it and you don't pay attention to it. But the hypoxic drive is like when these people it's like, well, I don't have enough oxygen, I'm going to breathe more. But when they do get enough oxygen, their bodies will say, hey, I don't need to breathe anymore. I got enough. So hypoxia, the brain is one of the first things that tells on itself when it's without that. It may simply being restless, acting up, getting anxious. I've seen people that just started developing a fast respiratory rate before. So that restless, irritability, apprehension, they're acting anxious or excited, just kind of out of the norm of what they maybe should be in view of the circumstance. Think of that maybe early signs of hypoxia. Let's don't wait till it gets bad, because a lot of times once it gets bad, it's hard to turn around. And these patients, if they're in early signs of hypoxia, once they start getting in a deeper state of it, they may be very, very difficult to control to the point to where you can't do anything to them until they pass out pretty much. But of course, the later the signs they get, cyanosis, that is without oxygen. You got blood flow, but you don't have any oxygen in it. That's when they start turning blue. Mental status changes. They get unresponsive. They may not be able to answer questions appropriately. That is signs that the hypoxia is pretty significant. Now, many times you can have enough blood getting to those alveoli, but there's no gas exchange taking place. And we call this a ventilation perfusion or VQ mismatch. And what's going on here is the perfusion, the blood is getting there, but the ventilation, but the air is getting there, but the blood may not be getting it where it needs to be. There again, what could cause that, like heart failure with a pulmonary edema or fluid building up in the lungs to form that barrier, or they could have a chest injury and that part of the lung is inflamed and it's not getting the oxygen exchange that it needs, although the blood may be getting through there. So that's what we call a mismatch. Back when we were flying we had patients on ventilators. Sometimes we would see to where their pressure was normal. We were moving the right amount of tidal volume in and out. We had the vent settings set correctly, and however, it may be because there's some type of a respiratory issue going on, where they might have ARES or acute respiratory distress syndrome, to where we're getting it there. It's just the lungs aren't able to use it. They won't use it. They're not able to. There's a barrier. The door's locked. They can't get through. So that's kind of what that type of injury means. So some factors that would really affect ventilation. Of course, we talk about interruptions to the central peripheral nervous system. Hey, are they injured? Do we have an injured spinal cord that's causing it not to receive or transmit messages? It's causing some type of paralysis. Hypercapnia is, let's say you got all kinds of, you got too much CO2 built up into the bloodstream. And that can affect ventilation, because you're, before, and you can't really tell unless you got that type of equipment to measure it with. But many times someone may, we want them to breathe between 12 and 20 minutes per minute. But if they got a hypercapnia, too much CO2 in there, and like I said, without a blood gas, you're not going to be able to know that. I'm just telling you this for just some information. Then that person would probably need to breathe a lot, be put on a vent or bagged faster than what their normal rate would be in order to blow that off. Head trauma, spinal cord injury. Remember, head trauma, the brain swelling, that brainstem swelling, that medullary respiratory system, apneutic system is going to be altered, and they may have erratic or irregular breathing difficulties to where they're not able to properly get the tidal volume, the minute volume in place. Muscular dystrophy, it's an autoimmune disease. A lot of effects. It starts off usually in childhood and develops more and more later on to where their diaphragm and things don't work. It's simply in their chest muscles and their thoracic muscles do not work enough in order to be able to properly ventilate and move air. Also with like LAS or they call it Lou Gehrig's disease as well, is also a neurological disease that eventually gets to the point to where the ventilatory muscles simply do not work anymore. Allergic reactions, when the histamines are released into the bloodstream and respiratory system, one way that works is that causes bronchial constriction. It causes restrictive airflow. You'll hear wheezing, but that restricts ventilation. That's factors that can happen, like not always immediate, but it can develop as time goes on during the call. Of course, we talk about extrinsic factors. That's trauma or things that occurred outside the body, where they shot, where they hit, they have blunt force trauma, something that's causing trauma to the respiratory system that causes it not be able to work right. That's a primary injury. Or are they choked? Is something blocking it? Respiratory splinting. Someone that might have broke ribs or chest trauma where they're not able to take a deep breath. That they're not able to take a deep enough breath, their minute volume goes down. Instead of taking real deep breaths, they may start having real fast breath. And when they start breathing real fast, they they may start blowing off too much CO2, and then they'll start getting in this hyperventilation syndrome. So that's why, remember, anybody that has a respiratory rate that's too low or too slow, too low, too slow, too fast, they're not getting that minute volume that they need. Let's help them out. Let's put them on oxygen. They may even need to have a bag valve mask to have assisted ventilation. So think about what's going on with that. They got to have that minute volume. They've got to move so much in and so much out per minute. And they do it by how fast and then how deep they breathe. If one of them is altered, help take care of the other one to make up for it. Hyper and hypo, there's those two terms again. Hypo is too slow, hyper is too fast. And it a lot of time that can have an effect because of what the pH level is in the blood. If it's too high, they're going to want to breathe fast to try to blow it off. And a lot of times, by slowing respiratory rate down, can help it catch up. So there again, back in reference to like carbon monoxide will cause you not to be able to get an accurate pulse ox reading. So don't depend on that alone. They need, of course, give them more high flow oxygen, but their skin may be red, cherry red. Oxygen may read 100%, but there again, their brain is being affected by this. So they can be unconscious and still have 100% pulse ox. But remember, look at your history, the history of present illness, the events surrounding the circumstance, and seeing how that what else might be going on with it. Now that stuff comes from the outside. Some internal factors, something that reduces the surface area, like COPD, pneumonia. This is blocking. These are barriers that block the gas exchange between the alveoli and the circulatory system. So it's a barrier, and you're not going to get accurate blood or pulse ox readings with that. And of course, the alveoli might not be functioning even. Remember, due to atelectasis or ARES, which is acute respiratory distress syndrome. And we're starting to transport a lot more sick patients. And this may become more obvious to a lot of people. We're seeing, we got COVID everywhere. And some of these patients are in the nursing homes, and some people having this stuff on top of other respiratory diseases, some that would have been sick anyway. And so we're going to start transporting more of these people. They lay there, they get septic, they get pneumonia. And I mean, how many people do we transport? They say, well, they got pneumonia, and they're in a bed, and they're not real active. And that's simply what's happening. These alveoli stop functioning, it simply builds up, and it creates a mess. Intrapulmonary shunting is when blood enters the lungs from the right side of the heart and bypasses alveoli and stuff. And you see this like in babies, right? About the time they're born. That blood is shunting inside the heart with newborns because they haven't needed their lungs because they've been inside their mom. So it takes a little bit for that to swap over. Some of them have delayed reactions with it. Sometimes it takes a couple hours around delivery before this happens. But it's called intrapulmonary shunting, and that's simply the blood doesn't go to the lungs; it just goes from one side of the heart to the other to the body because it's had to bypass that. And the ventricle, that ovum inside the heart has not closed up yet. That's what that means. Because respiration's too fast, too slow, it's not going to provide the amount of oxygen or minute volume someone needs. Pain and strong emotion, that going to make someone breathe fast or maybe not breathe deep enough, like if it's a chest wall pain, back pain. Sometimes abdominal pain can cause someone not to take the breaths that they need to take. Strong emotion, someone is angry, excited, breathing real fast, can't control that. That could be a factor as well. Hypoxia, lack of oxygen, and other conditions that affects the cells. What could that be? It could be someone in ketoacidosis, hypoglycemia, infection, sepsis. All of these are conditions that affects the cells that can cause problems with respiratory. Now, the lungs can work great but the circulatory system has to work good as well. So when problem with the circulatory system, blood and oxygen's not going to get to where it needs to get. Now it could be due to why is that? Is it simply leaking out and not getting there? Is the pump not working? Uh, is blood flow being obstructed? Like, for example, someone may have a tension pneumothorax, blood can't get pumped out where it needs to go. Do they have a pericardial tamponade? Blood's not able to be pumped to where it needs to go. The respiratory system is doing its job, now the circulatory system can't do its job. Things that may happen with this, we talked about the pneumothorax, hemothorax, and blood bleeding out in the chest cavity and not getting into the system. Pulmonary embolism. Uh, Pulmonary embolism, a lot of times it starts from blood clot in the leg, DVT, deep vascular thrombosis, and sometimes it can happen and a lot of times it happens in, like I've seen it happen in truck drivers. They sit still all day, they're driving, and I've worked a couple of codes with truck drivers. A lot of times they were purple from the nipple line up, and that is signs of the pulmonary embolism. So you think about, hey, what could be going on with this person? Females, especially the ones that smoke and are on birth control, are prone to pulmonary embolism. People that are in bed after surgery, certain types of surgery, a lot of times they'll put those PE stockings on their legs. They inflate, deflate, inflate, deflate. The whole time they're in the bed. That's to prevent some types of pulmonary embolism. But these pulmonary embolisms, a lot of times they can be small, just cause a lot of discomfort. However, sometimes they can be big and block off a whole area of the lung, and it can exchange, and they can be fatal that way. But it does happen. So those are some factors that can affect that. Heart failure. We talked about the tamponade, but like heart failure itself, let's say congestive heart failure, pulmonary edema, when the heart is not able to pump blood through the system that's requiring it, the left side of the heart may be given out and blood starts backing up into the lungs because it can't pump it out quick enough. And that causes, it's not just a cardiac problem, but then it's a pulmonary problem because that fluid is building up in the lungs. It can't do the gas exchange that it needs. Those vessels in those small blood vessels can't contain the fluid that it needs to, and it starts leaking out into the lungs. It starts coming out of those vessel walls, getting that vasodilation, and starts getting in the lungs. That's why sometimes with pulmonary edema, you'll see that pink frothy or that white frothy sputum. It's because the the alveoli, those capillaries cannot handle it anymore, and the blood won't take it, so they're going to put it back in the lungs. Of course, hemorrhagic shock. If the blood goes away, it can't be used. You can't carry blood if it can't carry oxygen if it ain't there. And the vasodilatory shock is a lot of times neurogenic. It's where the vessels dilate and are not able to maintain adequate blood pressure to get the blood and oxygen where it needs to go. So when you have a problem with the hypoventilation, hyperventilation, when this is affected, when it's just think about what's happening, because it's supposed to breathe 12 to 20 times a minute for an adult is what usually to maintain homeostasis. Now, if I have a respiratory acidosis, pH is low, EtCO2 is going to be high. If you remember the word roam, and like I said, this is just extra information. It's just no knowledge is wasted. But like if you have if you're able to look at a pH scale or ABG, arterial blood gas, one reason they look at how they figure out a respiratory acidosis from a metabolic acidosis. You think a respiratory opposite, metabolic equal, Rome. If I have a respiratory acidosis, I want to have a low pH, but I want to have a high EtCO2. You see, it's opposite. That's corrected by deep and fast ventilations. A respiratory alkalosis, it means I'm going to have a high pH, and my EtCO2 is going to be high as well. Metabolic, I'm going to have a low pH, but a high bicarb, and same with metabolic, it's going to be just opposite. And that's just FYI. You don't have to remember that or anything, but that's kind of the way that those work. So when you have acidosis, your body's going to try to breathe hard to blow it off. when you have alkalosis, they may be breathing fast already, and they're blowing off more CO2 than they need to. They're probably breathing fast already if they're in alkalosis, and they have to correct that in order to bring it down. So, treatment for hyperventilation syndrome focus on restoring normal respiratory rate to increase CO2 level. Now, I know back in the old day when I went through it, we put a paper bag on somebody's face, let them breathe in and out. Follow local protocol on that, on whatever it says. I'm not giving you medical advice, telling you what to do, because they say follow local protocol because there was people putting people on paper bags without getting a full history of what's going on. They actually were having heart attacks and things like that. They misdiagnosed it in the field and caused all kind of problems for the rest of us. So follow local guidelines on what that scenario is. Breathing people should be able to talk, have a conversation while breathing. They should be able to say full sentences. Remember your normal respiratory rate, 12 to 20 breaths per minute. Depth, they shouldn't look uncomfortable when they're taking breaths. Every now and then, an occasional sigh or yawn may happen. And sometimes when that happens, a lot of time that happens when people are like at rest or maybe bored, because they're sitting there, they're not moving their lungs a whole lot. They might be reading a book, watching TV, and they're not using their respiratory status a whole lot. And what happens is that CO2 may build up a little bit, and your body just takes a big, deep breath or a big sigh and lets it out. And that's kind of like might be what's going on with that. And you know how they say yawns are catching? I've always heard that, and I've read stuff back and forth on it. And they say maybe one reason that is that for most part, when people are yawning and stuff like that, one starts yawning, you're probably listening to a boring PowerPoint lecture or in a classroom or something like that, or you're in a similar scenario, a similar location to where everybody may be having the same requirements. So that's just one that's out there. I don't know if you find something different, I'd like to hear about it. But remember, normal respirations, adequate tidal volume, regular pattern, and you shouldn't be able to really hear them breathe very loud and stuff. So that's what normal is. Remember normal, and that way you can tell when something's wrong. Because respiratory problems, to me, is one of the most difficult calls to work. And therefore, I don't always know what's wrong. I have to look at what's not right. Well, they're breathing 30 times a minute. Okay, there's something wrong. That's not right. They're not breathing very shallow. They're not breathing very deep. They're breathing shallow. I know that's not right. Do I know what's wrong yet? No, but I know what ain't right. Man, they're irregular. They're breathing this real deep type breathing. They start slowing down. I know that's not right. So anyway, that's the kind of way I have to look at respiratory, because as we've talked about just a few things, they got asthma, CHF, COPD, they got cystic fibrosis, they got all kind of stuff out there. And I don't know, I can't tell a lot of times what it is, but I can tell you what's not right. So we need to really learn the normal, and then try to put normal back. That's the way we have to treat respiratory problems sometimes. It's like, well, I'm not sure what to do with this. I'm not sure which way it's going. Well, what's not right about it? Well, they're breathing too slow. Okay, well, make them breathe the right amount. Well, they're not breathing deep enough. Okay, well, make them breathe deep enough. So that's the kind of way I have to look at respiratory. I've been doing this a long time, and respiratory is challenging. So just think about, if you don't know what's wrong, look at what ain't right and see what you can do about making it right. So, respiratory distress, it simply means, hey, they're having trouble. It means the respiratory system's still working, but they got trouble. They're having to work to make it work. And it could be, airway obstructions, inadequate ventilation, impairment of the muscles or the nervous system. But this has to be jumped on right away. Don't wait to see how bad it gets, because I've been there. I've been that medic that's like, well, let me see what happens next. And you almost didn't get somebody turned around. And we shouldn't use mistakes mistakes is something you learn by. And I was a young medic when some of those things happened, and it's like nobody died or anything like that. However, what I'm saying is a lot of times other people's mistakes is stuff to be learned by and passed on. So we want to think about, when you see somebody that's having respiratory issues, respiratory distress, don't wait to see how bad it gets. Hey, I'm having trouble breathing. Okay, jump on it. they're having signs of hypoxia, fix it, oxygen. That's as far as you go. That's why we treat these life-threatening emergencies as we find them. We don't go to the next step. So that's why I don't wait to see how bad it gets, because a lot of respiratory patients, especially those with like flash pulmonary edema, uh, sudden, cardiac failure that comes on all of a sudden, or severe pulmonary edema, those patients, if it's not jumped on quick, they will die on you. I've had them happen real quick before. So I had one the other night, uh, tripod position, mottled skin. His skin was so wet that the EKG pads just slid off of him. And, I've seen that before, and it did take long before I was having to tube him and intubate him. We got into the hospital, man, ended up doing okay, but because of experience, uh, got him on CPAP right away. He was new to it. It scared him. Had to coach him, but he ended up making a good recovery, I was told. So there again, don't wait for stuff bad to happen. Jump on this and head it off. What we look at here is like determining patient's respiratory distress. When we talk about how are they positioned, are they laying back? Are they laying flat? They may be laying flat. I mean, who would lay flat if you can't breathe? Maybe someone that can't help it. So, if they're laying flat and they're having trouble breathing, hey, let's set them up, see if that changes anything. And remember that term, orthopnea, as trouble breathing when laying flat. So, but remember that term. So how are they positioned? Are they sitting up on the other side of the bed? Are they in a tripod position? Are they in a sniffing position? Uh, are they laying on their side, laying on one side or the other, saying they can't breathe? How hard are they working at it? Are they focused on their breathing? Could it be the fact that if they're distracted from it, the phone rings, they stop talking, they answer the phone, not drawn, you're like, well, okay, it might not be a whole lot going on. But there again, ask yourselves these questions. Is there adequate rise and fall of the chest? And these are things you can do before even touching a patient. I always note, even in my transfers, symmetrical expansion of the chest. Get in a habit of looking at everybody. Well, they got symmetrical extension of the chest. It's adequate rise and fall. Are they gasping? No, they're struggling, but they're not gasping. Gasping means, it's just kind of they take a deep breath and they take another one and they take another one. Uh, it's like each breath is not satisfying enough, so they got to get another one. They're short. And a lot of times they're real quick to go in and they don't come out as fast. Look at their skin color. Is it moist? Is it clammy? Is it diaphoretic? Pale, mottled, cyanosis? Look at that when you're walking in. And this is all done without any laying on of the hands at this point. Flaring of the nostrils and the nares, you see that more so in kids. But is any of this is what you recognize this problem from across the room. Pursed lips. Are they really concentrating on getting this air out? You see this a lot of times in like COPD patients. They can get the air in, but it's getting it out that's the problem. So they kind of actually, they'll take a deep breath, and then they actually have to blow that air out. They have to think about blowing this out. And when people are breathing in, do they have the retractions, the clavicular contractions around retractions around the collarbones, the shoulders? In younger kids, maybe the xiphoid process, even adults, sometimes xiphoid process in that area, intercostal muscles. Are they retracting? Are they having to use extra muscles? They use their shoulders. They taking deep breaths, or like even some people even arch arch their back backwards to take these breaths. And there again, is it symmetrical? Is there one side or the other moving different? And that can happen not always due to trauma, but it may be a big pneumonia in there that's not allowing them to move that side of the chest. So note symmetrical chest rise and fall on everybody. And now, as far as we talk about the quick breath and prolonged exhalation, that's when you usually see the pursed lips. They'll take a deep breath real quick, and then they'll take their time to blow it out. This is kind of like they're blowing out, like they're trying to whistle. This guy here looks real sick. He's got, you can see the abdominal muscles are working with him. He's got intercostal retractions, intercostal muscular contractions. He's having retractions around his sternocleidoid mastoid muscles above the collarbones. And this guy, if he's having that much trouble breathing in that type of a position, you figure he's probably pending respiratory failure. Because for the most part, someone gets to at that point, they don't want to lay back. They'll fight you. They'll get very combative at this point and try to get them to lay back. Remember the minute volume we talked about? People need a certain minute volume in order to survive, and that's usually maintained in most adults that are not in distress between 12 to 20 breaths per minute. So is it slower than that or is it higher than that? That's the first thing you look at. Hey, does it look like they're having trouble? What's the respiratory rate? When we talk about too fast or too slow, if you're in an immediate assessment, you figure, okay, it's less than 12, that's too slow, it's greater than 20, it's too fast. And it really don't take me long time to get a real quick assessment of what the breathing rate is. So remember, they got to have a certain amount of minute volume. If they're not making those numbers there, then they need like supplemental O2 or something to help them out, or they might need some other type of intervention. Now, how are their breathing rate? Are they breathing 4 or 5 times a minute real fast and slowing down? If they're conscious in doing that, there may be something going on that they're not able to control. A lot of times unconscious patients will have an irregular breathing rate, like Shane Stokes, Biats, or Kussmaul's. Then you think about their lung sounds. Can you hear it from across the room? Noisy. Remember we talked about back and forth, listening to the breath sounds, listen to the back, axillary areas as well as the front. And is one side more diminished than the other? Or do you have someone that has an increased work of breathing and you don't hear any lung sounds much at all? That's simply because they may not be moving any air at all. And why is that? They may be having a bad asthma attack. They may have bronchoconstriction, but if they're not moving any air, you're not going to hear it. That's why sometimes the bronchial dilators and things will open that up to where you open it up enough to where you can get air movement, and then you can hear those breath sounds. So just because you have no breath sounds, if you didn't hear anything, then look at, hey, what is their chest rise and fall like? Are they moving air in? And if they're trying to or they're not, you got to think, man, there's something causing this problem, and they need interventions. Depending on what level of training you're at, maybe all you can do is assist with bronchodilators and high flow oxygen and go get to where you need to get. In some local areas, you may be able to do a little more for these patients, but these type patients, once they get to this point, they pretty much need some pretty advanced drugs in order to get this turned around a lot of times. We talk about air going in, it's got to come out. You're not really able to measure how much air is coming out, but sometimes you'll see this in these COPD patients. You'll see them take a breath. It looks like they take a normal breath, but when they go to breathe out, it's just like they're having problems. They can't get it all out, and that's what happens. It causes their chest to be hyperexpanded. And that one at the bottom just reiterates what I was talking about as far as having unequal chest expansion. Unequal or inadequate, that has to do with the tidal volume. Remember, they got to have a certain minute volume in order to be able to survive. The staccato speech patterns, that is simply someone that's like, if you remember staccato, if you never can read music or anything staccato, but it might be they're trying to talk and you ask them, sir, how long have you been feeling like this? And there'll be something like, there's this accented, forceful speech patterns, which is like you hear every other word, or you hear one come through every now and then, but it's really accented. If you can hear their breathing, you shouldn't be able to hear breathing. It's normal. Feel for air movement, of course. That if they're unconscious, you're not able to adequately look at this with them telling you or them participating. Make sure you can feel the air move. And pulsus paradoxus. Now, take pulses on each side of the body when you have someone with a cardiac or respiratory event. And the reason that is what we are looking for is, remember that a hyperventilated chest or too much air in the thorax causes reduced cardiac output. And pulsus paradoxus, a lot of times, and you see it in younger kids many times, ones that are in puberty or prepubescent, And what's going on with them is that they you can take their pulse rate and you tell them to take a deep breath, and due to the intrathoracic pressure that's already in their lungs, they take that deep breath, and it actually reduces uh, cardiac output. Many times it will slow the heart rate down during deep inspiration, and it will go back to its normal rate when they exhale. So there again, note that when you've taken somebody's pulse, tell them to take a deep breath in and out and see if that changes. And that simply means that the intrathoracic pressure inside the chest is great. It don't necessarily mean that something bad's wrong, because you do see this a lot of time in children. The brain centers in the medulla, the apneutic center of the brain, when they, they're controlled respiratory rate, depth, volume. They when they are impaired, it goes along with severe head injuries or cerebral edema. When those areas are being impacted or pressure put against them, you may have the airways, the ventilation rate stuff almost gets reflexive. Remember, we talked about the neurotaxic areas of the breathing system, to where it actually tries to impede uh, the influence on respiratory drive. So we had like a Shane Stokes type breathing, and what happens is that that center of the brain actually tries to impede breathing to a point when it gets that damaged, to where it'll slow breathing down, and then the body has a reflex: is wait, I can't survive without this. I got to breathe deep. So it'll start breathing and override it. You'll get the respirations will start out very shallow, get real deep, they're real fast, and then they'll taper off again. And then they simply override that inhibiting reflex of the brain again and start over. So this is usually seen during certain types of head injuries where they have intracerebral pressure. Now, agonal respirations or agonal gasp are simply that. People try to take a deep breath, or you see it a lot of time before someone codes, or when they're about to code, or even uh, you see that reflex sometime when you're actually starting to code somebody, and it's a very fresh, is their mouth will open and close. It's almost like they try to take a gasp, but nothing happens. Uh, and it can happen even after the heart stopped, because you still got a little bit of residual capacity going on. So agonal respirations mean ineffective breaths. They try to, they're going through the motion, but nothing ever really happens. It's a grave sign. These people are fixing to code on you if they have not already. So respiratory patients, remember, don't wait to see how bad something gets. Jump on it early and hang on, because once they start to get to that point of spiraling downward, then they're going to be hard to turn around if they do. So again, it focuses a lot on, but again, it focuses a lot on appearance from across the room and what you see when you walk in. Skin color, level of consciousness, that's how good is it working. Hopefully someone's there to know what kind of a baseline they are. Hey, are they always confused and acting inappropriately, responding words? They may say yes, they are. Or they'll say, hey, no, this is brand new. They normally are not like this at all. So know what a baseline is. So try to find out what a baseline is. If you don't know, then just treat for the worst case scenario. After you do the looking part, the viewing part, the visual, like, okay, I've got an impression, then that's when you want to start getting into your equipment. Go ahead, pulse oximetry, but don't rely on that totally to make sure of what you're going to do or what you're not going to do. Remember, that can always have issues. So don't let that be the only thing that helps guide you in treating a patient. So they really only pick up the pulsating blood vessels that are like in the fingers, if they're on the ears, something of that matter. Now, if someone's in cardiogenic shock and the blood's not getting there, or if they're cardiac arrest, you're not going to have a good reading at all. And Anybody with respiratory problems should be monitored like this. Anybody that's on oxygen, because you want to see what your changes are. It also can help you identify if something starts to go wrong, and it can, for example, it's a good idea if someone has like a broke leg or a broke extremity, you're able to evaluate what kind of blood flow and stuff you got to it, uh, that you might be going to that extremity. Now, we talked about earlier in the hospital when some people may be not moving around as much as what they're used to. The atelectasis may set in. They don't get to take these deep breaths and things like they should. Well, what they start using is what they call a peak expiratory flow measurement. And that simply, it helps a couple things. It measures how good the patient's responding to treatment. It also helps keep it's kind of like forms of back pressure on the lungs to keep the alveoli inflated and not collapsing. And if someone's being measured or a chronic breathing problems, or if they're in a hospital being treated for that, then it also monitors for if there's any worsening condition. Sometimes it starts to go down, like people that have been in there for a while. Hey, yesterday you were blowing at this amount, today you're blowing at this amount. We need to do a chest x-ray and make sure you don't have a pneumonia or something forming like that. Arterial blood gases is, some community or critical care services may do this in the field. At the advanced EMT level, you're not, but we need to kind of understand how it does work. And what this is they draw blood from an artery, usually the radial artery, and it's got that's what the heart is delivering to the body. That's why they measure it like that. It measures pH, it measures bicarb, it measures amount of hemoglobin, the hematocrit. It measures those numbers in there to kind of tell how it's all working. The Untitled CO2. Remember the other night we talked about it goes on the end of the airway, and it monitors the amount of carbon dioxide that's exhaled in the air. Now, if you're perfusing and you've got this in the right place in the airways, and they're actually saying now you should put it on someone without an advanced airway, they got the nasal cannula type. I'll show you in just a couple seconds. And they got the type that fits on to the end of an advanced airway. And it measures perfusion because it shows you the amount of CO2 that's being delivered to the device. The colorimetric, those don't work good when they get wet, but when you put it in, it should change from purple to yellow, and it measures the amount of oxygen or carbon dioxide coming out with each breath. And it should be between the numbers 35 and 45. So these things do a couple of, the colorimetric are the one that changes the color. The one on the bottom is the capnometer. And it actually measures the amount of CO2 coming out. And also another thing is it helps measure the actual respiratory rate. So this kind of gives you two things that's going on. Let's say that CO2 starts coming up to about 50. Then whoever's controlling that airway would want to start bagging the patient faster. They want to increase the respiratory rate to blow off that excess CO2. Once it slows back down between around 45, below that, then they can go back down for the respiratory rate again. That's one how capnometry can be used with the advanced airway. And in fact, anybody that's been intubated or after intubated with advanced airway, this should be on the patient all the way to the hospital, continuous monitoring to make sure that the airway's in place and the O2 is being delivered, the CO2 is being removed. Now, you see that 38 on there. Now, what this shows here is this is the device, the waveform capnography that's on many of the monitors. Now, this you can't see all the way up to the top. The way they got this set, it's probably set to this is set to 0 to 40. Remember, we want 35 to 45, and that other one said it was at 38. So if you look at where that dot is on the peak of this waveform, it's around 38. So that's at the end of exhalation. When it exhales, it goes up, it raises, it squares off, and as soon as the body starts to inhale, that's when it drops back to the bottom. And this is a good indicator of how good they're perfusing. Now, if you were doing CPR on this person and they were intubated, that number would only be probably about 10, 15. And that's all you're going to get with at least you got one. If you got a reading, then you know you're in the right place. However, with cardiac arrest, it may be only like 10 to 15. Now, let's say you're doing CPR, you got about 10 to 15, and all of a sudden it shoots up to 35 to 40. The only way that does that is with perfusing. That's when usually you check and see if they've got a pulse that come back. Because usually when it goes that high, it's only because their heart is coming back, because you're not going to do CPR good enough to put it that high. These are some devices that measure EtCO2, how we measure it. Now, the nasal cannula one, I love those. You can put those on just about everybody, CPAP or anybody like that. They should have that on as well. And it also delivers oxygen through it as well. Many of them are set up to deliver oxygen. So like with COPD patients you're wanting to monitor for EtCO2 problems or respiratory distress problems, that is a good device to use. A lot of places don't use them because they're so expensive. Each one of those are probably about $22, $25, something like that. For the top one, the bottom one, probably $8 to $10. The one on the bottom is the one that attaches to ET tubes or on the end of BVM masks. So that's the difference in those two. But a lot of places, like I said, the top one, they simply just don't get them because they're so expensive. And a lot of people misappropriately use them. Like they may want to, instead of using a regular oxygen cannula on someone that may just be mildly short of breath, they'll use those on everybody. And as you can see how it gets expensive. That's why you don't see a whole lot of them anymore. It's a great tool and not utilized enough for the most part. Now back to the basics. Opening the airway. That's what these next few slides cover. But we see how we talked about earlier, how there's no way that you can swallow your tongue, despite what a lot of old people say, because it's attached to the bottom of the mouth. However, it will fall back against the back of the throat and it will block that airway. You can see where the epiglottis is, where it is supposed to go downward to cover the trachea. However, in this point, the tongue is against the back of it and there's no air moving at all. Simply doing a head tilt chin lift will bring that tongue away from the back of the throat. Now, the tongue is one of the biggest objects that cause airway obstruction. So remember, head tilt chin lift, bring the head back. Jaw thrust, if you suspect any type of trauma, so to reduce any type of spinal injury. The tongue jaw lift, now this can work as well. You simply reach in, pull it up. I don't like doing this because I don't like sticking my hand in people's mouth unless I really have to. But there's a couple of ways this could be utilized, in fact, for the simple reason you may want to suction to be able to get it in there deep enough to see what you're doing. This can be used also to put, like, I've used it before when I wanted to put a combi tube in or a King Airway. That has assisted in that, as a matter of fact. So that is also when you maybe want to look into the back of the mouth. Recovery position. Hey, if there's no trauma involved, and if you don't have the equipment, if you're probably waiting on some transport, then if they're breathing on their own, turn them on the recovery position so they can maintain this sideways to where it allows for drainage and it allows that the tongue won't fall back against the back of the throat. And if they're breathing on their own, it will help them maintain their own airway. Now, suctioning. Many times I see crews come in the house without suction. Now, I'd much rather bring it in and then not need it, have to take it back out. But if you need suction, you need it in a hurry and you need it fast. Because, I've seen it to where people would just go ahead and bag someone anyway, and they blow all that back down into the lungs, and that acid in the stomach contents eats the lungs up, causes pneumonia. So suctioning is a priority. Something's in the way of the airway, you get it out. You hear something in there, you suction it out. If you hear anything gurgling or bubbling at all, it needs to be suctioned out. So that needs to be readily available, and you don't wait on it to. And because a lot of time, by the time somebody goes back to the truck, you've lost that precious time. Not to mention, probably cause some type of damage or aspiration. Now, some places don't want you to open up the tip like the Yonker tip or trochanter, whichever kind you use. But if they don't, then I would have it ready to be hooked up pretty quick, because I know when I need it real quick. And nothing I can't stand is when the suction canister or whatever is not ready. So you got wide bore, thick walled, non-kinking type tubing. You got this like rigid catheters that you can have to reach into like to the back of the throat. There's also the soft type catheters, suction catheters that goes down like ET tubes or sometimes nasally. And a lot of times somebody has to have saline, some type of saline or stir water, because the secretions that they're trying to suction out gets very thick sometimes and has to be diluted. So here's a couple different ones. The Yonker, that's a brand name. That's not the actual tip of it, but it's called the tonsil tip catheter, which is one at the top. Little bitty suction hole. It doesn't work good for a lot of thick stuff. Then you got the hole that you place your finger over to be able to suction it out. And of course the top or the soft or the French tip is also good for like suctioning out ET tubes or getting stuff from the back of the airway, or even smaller individuals for that. Now, all I can say here is know how to operate your suction unit. There are a lot of different portables out there. If it's on your truck, you should be more than familiar with how to use it. Now, down to the bottom here, according to this text, it talks about suctioning time limits to 15 seconds for adults, 10 seconds for children, and 5 seconds for infants. That's what the book's saying. However, I'm going to ask you, let's say you suction for 15 seconds and this patient's mouth is still full of vomit. What are you going to do then? It's got to come out. So there again, well, I suctioned for 15 seconds and I put the bag on and started bagging him and blew that vomit in the lungs. There again, that doesn't make any sense. You can't do that. So when I've suctioned airways out before, sometimes I've had to put the suction device in, move it over to one side, and intubate past it, because there was so much fluid and blood coming up that suction on that one time just wasn't going to do it. So for the most part, if it's still coming up, you got to suction it out. You can't blow it back down into the airway. So, but like I said, as far as the text goes on this, if it asks you that in the quiz, just remember those numbers. However, there again, even like for an infant, well, I suctioned for 5 seconds and the mouth was still full of fluid, you'd probably get in more trouble or cause that infant more harm if you blew what was left in there down in the lungs. This is the soft ones. The flexible ones is usually good for suction out an ET tube. Now, for the most part, the paramedics do the ET tubes, and they should be doing the suction. However, this is the way that this works. Now, they may ask for assistance sometime, but follow your local guidelines on that as far as whether or not you can suction ET tubes. But many times it does have to be done, especially if that patient was suffering from congestive heart failure, pulmonary edema. That fluid is going to keep accumulating in the lungs, and it needs to be suctioned out. I've seen it to the point to where it just bubbled from the top. It looked like a washing machine from running over, but that has to be suctioned out. Oral pharyngeal airways, remember, it prevents the tongue from obstructing the glottis. Remember, I showed you the pictures of the airways earlier about as far as getting the right size in. If it's too small, it's not going to go back far enough to pull the tongue away from the back of the throat. If it's too large, it can actually block the laryngeal opening. Now remember that these are, should be used with people with no gag reflex, unresponsive. Any patient that's being bagged with a bag valve mask should have an oral airway in place as well, for the simple reason you want to be able to get that air in. Now, gag reflexes, you can make things worse with this. They may vomit, may not let you put it in, but hopefully everybody is familiar with putting those in. Now, my favorite, if I'm doing a BVM with somebody and if they're able to be ventilated through the nose of the BVM, I do like the nasal airways the best. That's a personal choice. But these a lot of times can be tolerated better if someone that has an altered airway, altered mental status, or someone that still has a gag reflex intact. They you they may tolerate these better. Now, head trauma is not an absolute contraindication for these, even though in the past it used to be absolute. It just remember that is a possibility in certain this if it was to go to a basilar skull fracture. But the studies, they can't find any reliable studies where that's actually happened. I know they talked about it. I know in the old days I'd heard a bunch of stuff about it, but the latest PH-TLS standards says there's actually not any documented evidence where that's actually went up into somebody's head before. So always also due to the vasculature mucosa of the brain, I'm sorry, of the nasal cavity, these may cause some bleeding when you put them in. So a little bleeding is a possible side effect to these, but a lot of bleeding is one thing, but a little bleeding, it's probably not a real big deal with that. But just remember, there are some vessels inside the nose and stuff that if someone has high blood pressure or bleeding tendencies, takes Coumadin, then again, would not want to. I might think twice about putting that in because you rupture a blood vessel in the head with that, or the nose, and they could bleed a lot from it and cause aspiration. So the common sense wise or making informed decisions. Now, like I said, there was no evidence of that going up into the skull. However, if you do see CSF or blood coming out of the nose, then, I'd probably think twice about it. It might not only just go up in the back of the head, but it could penetrate into a sinus or something like that as well. So just remember, they got direct nasal trauma and things like that. It probably would not be a good idea to do it, but just general head trauma in itself, I would just do it with a high regard of caution or see what your protocol is on that. Now, the as far as oxygen administration tonight, we're going to talk about some of the O2 cylinders. Always use the right. I ain't gonna tell you what each size is and things like that, but also make sure you get the right color and what it is. The there was I got on an ambulance once in New Orleans who got their oxygen from a local hospital, and so we go to do our morning checkoff. The night crew said they had changed it out, so we're doing a checkoff that morning. And when we go to check the oxygen, it's a big old black tank. It was like pure nitrous oxide somebody had put on there instead of oxygen, and they did it in the dark. There is such thing as flashlights and things like that, but just think about what would have happened. They get pure nitrous. So there again, make sure it's the right color. Green is oxygen, and everybody should know how to work those at this point. With liquid oxygen, that's is liquid. It's usually got to be cooled, stored in specific tanks. You're not going to have those on the trucks. They here's the way they're transported. Now, a lot of these cylinders, these regulators, are the way they're threaded, the way that they are pinned. There's not going to allow you to put like an oxygen regulator connected to a CO2 regulator or something of that matter. Now, that's what most of them are supposed to be. However, now this was a long time ago that nitrous tank was put on there. So, and it was connected up. Like I said, it was a long time ago. I'm going to bore to death about these regulators. We've been around them, be familiar with them, be familiar with the ones that you got. That also don't leave the next crew with not enough oxygen. Know how long the oxygen is going to last in some of these tanks. Now, if you work in a urban area and you don't go out of town much, you don't have a long transport time, you might can get by with letting it get down to 700, 600 pounds. But if you're in a rural area, think about if you got these long transports, you don't want to get caught halfway on a trip and then run out of oxygen. The flow meters, be familiar with those, know how to read them, know how to use them, know what they're capable of. A lot of these flow meters are not capable of supplying a ventilator or a BiPAP or a CPAP machine. In those cases, a lot of times what they have to do is be hooked to a special part on a regulator, but a lot of time going through the regular top regulator, like that Christmas tree, like that, will not support those devices. Okay. Oxygen is flammable. You can get hurt with it. Oxygen toxicity. Remember, we're going away from where everybody gets high flow oxygen all the time. The desired O2 rate that we want to get at, SpO2, is anywhere from like 94 to 99, depending on the patient. But too much oxygen, high flow oxygen, can cause cellular damage. Oxygen is a vasoconstriction. That's why even in someone with severe head injury, remember the ETCO2, we don't want to hyperventilate them unless it's to the point of where they are herniating, because what happens is oxygen causes vasoconstriction. And even with, think about that, even with cardiac patients, they need enough to maintain an adequate SpO2. However, you give them too much, it causes the vessels of the heart to contract. And what's that going to do? Also, with a brain that needs oxygen, or that needs blood flow and oxygen, too much oxygen will actually cause the blood vessels to constrict and reduce blood flow. That's why, remember your respiratory rates, try to keep things within that parameter. Proper devices, non-rebreathers, bag valve devices, nasal cannulas, know which ones properly fit these patients. Now, nasal cannulas, for a regular one, up to 6 liters or so. However, sometimes people have, before we would intubate somebody, pre-oxygenate, we would give 10, 12, 15 liters of oxygen through a cannula to hyperoxygenate these people before intubation. And people are like, well, you can't do that. But if you got a cannula hooked up to a Christmas tree, you turn it on 10 liters, where else is it going to go? So think about that. So that, you normally don't use it for that high. However, they may be a case to where they can't tolerate a mask or something for some reason. So, focus your local guidelines on that. Now, non-rebreathing mask, preferred device in a pre-hospital setting if it is indicated. Now, if they got if they're apneic or poor respiratory effort, remember, it's not going to work. It takes cooperation. They have to be breathing on their own, because it's not going to force air in if it can't get there. So how much O2 do you need in there? 10, 12, 15 liters. I usually put it on there enough until the bag is inflated, the reservoir stays inflated. Nasal cannula, remember those. The partial non-rebreathing mask, hardly ever see these anymore. It's just like a non-rebreathing mask, but it just doesn't have the little one-way valve flaps on it. And a venturi mask, we don't use those in the field very much. However, you may see them on interfacility transports. And that's like if the patient needs a certain amount of FiO2 delivered, 24 to 40%, they have those settings on there. You might have your regulator set at a certain rate. However, with these venti masks, they only going to get a certain percentage. Tracheostomy mask, simply, they're not always available everywhere, but an O2 mask over that will work adequately as well. Humidifiers, a lot of places don't have them on the trucks if they're short term, but if it's going to be a long term transport, 30 minutes or more, something like that, a humidifier would be a great thing, full of stir water, because oxygen dries out the mucous membranes, makes people uncomfortable pretty quick. So, I'm going to stop right there for tonight, because we'll continue this on Wednesday night. But right now, tonight, I'm going to stop on slide 87. And does anybody have any comments, questions, or concerns tonight so far?
No, sir, you're doing a good job.
Man, I wish it's hard to make some of this stuff interesting, but we're getting toward the good stuff, We're getting toward the good stuff. And a lot of this stuff I just have to okay, I don't like reading from PowerPoint. Sometimes I use them as a guideline. A lot of it I just play back through stuff that I've done before. But anyway, and I'm going to get like tonight, we won't have as many slides coming up next meeting. But I want to try to look at the material and try to pull some stuff over from critical care slides and things like that may give you some better pictures to look at than what that we got in here. And it still follows the parameters and everything. However, it's and you can only get so much out of what's printed, and make better sense to you. But I know this chemical stuff, this cellular level stuff is very interesting. I mean, it's not very interesting, very important, but it is really hard to get a grasp on it. And then when you see it's coming into play later, then things will work out. It'll come to better for you. But anyway, I appreciate y'all's patience tonight and everything. Been a crazy week at the house. We've had a little dog for 14 years. We had to put her down a couple of days ago, and that's been kind of a rough week. They become part of your family and stuff. But anyway, I'll start back to work Thursday night for a week. But I'll see y'all back here on Wednesday night at 6 o'clock. And tonight, your pin will be, let's say, 21811. 21811. That's on the 20. It's February 1st at 8:11. All right, guys.
All right. See you later, Lynn.
All right. Y'all have a good couple of days, and we'll see y'all later.
All right, you too.